of an upper motor neuron lesion. Pathological reflexes. These are also superficial reflexes mediated through the central nervous system. The significant fact is that they are present with an upper motor neuron lesion, whereas normally they would not be elicited. Therefore, in upper motor neuron lesions, the superficial reflexes will be absent, while the deep tendon reflexes are increased and pathological reflexes will be present. Deep tendon reflexes. Patellar tendon reflex or knee jerk L2, 3, 4. With the patient sitting over the edge of the examining table, locate and tap the patellar tendon with the reflex hammer. This can also be done in the supine position by flexing the knee slightly to put the patellar tendon on slight stretch. Achilles tendon reflex or ankle jerk S1, S2. With the patient sitting, passively dorsiflex the foot to the neutral position and tap the Achilles tendon. A plantar response indicates an intact reflex. In the supine position, the patient can cross one leg over the other, and with dorsiflexion of the foot again to neutral, tap the Achilles tendon. The reflex can also be elicited with the patient in the prone position and the knees flexed to 90 degrees, or with the patient kneeling on a chair. Under normal circumstances, the ankle jerk and the knee jerk can be detected easily. They may, however, require reinforcement, such as having the patient try to pull clasped hands apart in order to elicit the reflex. Posterior tibial tendon reflex L5. The posterior tibial tendon is tapped with the reflex hammer either just behind the medial malleolus or just proximal to the navicular tuberosity. Inversion and plantar flexion indicate the presence of a posterior tibial tendon reflex. This reflex for L5 is not elicitable in all patients, hence its absence may not be meaningful. However, presence on the uninvolved side and absence on the involved side is excellent evidence for an L5 nerve root lesion. I have found that frequently reinforcement is necessary in order to elicit this reflex. Medial hamstring reflex. The medial hamstrings can also be tested, but it is probably not an isolated L5 nerve root because of its multiple root innervation. The examiner's fingers are pressed against the medial hamstring tendons where they are readily palpable behind the knee. The fingers are struck with the reflex hammer, and the presence of the reflex can be detected by the examiner's fingers as well as the visual contraction of the hamstring muscles. Superficial reflexes. Abdominal reflex, cremasteric reflex, anal reflex. Abdominal reflex. Each quadrant is stroked by the end of the reflex hammer. The movement of the umbilicus is towards the quadrant that was stroked, and this designates the presence of the reflex. Cremasteric reflex. The inner side of the thigh is stroked with the end of the reflex hammer. With an intact cremasteric reflex, the scrotum on that side is pulled upwards by the cremasteric muscle. Anal reflex. The perianal skin is touched and the anal sphincter muscles should contract, denoting the presence of this superficial reflex, also called the anal wink. Pathological reflexes. Babinski test, Oppenheim test. Babinski test. Stroke the plantar surface of the foot along the lateral border and across the forefoot with a pointed instrument. In the normal patient, the toes plantar flex but in the positive test suggesting the presence of a pathological reflex, the big toe will extend and the lesser toes may splay and plantar flex. Occasionally, patients are so ticklish that the examiner must use another method to try and elicit the Babinski response. This is called the Oppenheim test. The examiner runs the fingernail along the crest of the tibia, eliciting an upgoing big toe and plantar flexion of the minor toes denotes the presence of a pathological reflex. Test to detect meningeal irritation or space-occupying lesions in the spinal cord. Koenig test. The patient lies in the supine position and places the hands behind the head and forcibly flexes the head onto the chest. A response of pain and its localization may be suggestive of meningeal irritation. Tests to detect increased intrathecal pressure. Pain produced by maneuvers which increase intraspinal fluid pressure may suggest intrathecal or extrathecal pathology. Milgram test, Nafziger test, Valsalva maneuver test, Milgram test. The patient lies supine on the examining table and is asked to raise both legs about 2 inches off the table. The ability to hold the legs in this position for 30 seconds or longer without pain suggests that intrathecal pathology may be ruled out. Nafziger test. Gently compress the jugular veins bilaterally for about 10 seconds. Then ask the patient to cough. Production of pain in the low back region is suggestive of pathology. Valsalva maneuver test. Forced expiration with the closed glottis increases the intraspinal fluid pressure. The reproduction of back and or leg pain suggests pathology. Special tests related to the neurological examination. As mentioned previously, the neurological examination, especially the sensory and motor aspects, are quite subjective, relying on the patient's response for sensory determination and on patient cooperation for motor function testing. In order to determine if a patient is cooperating fully with the examiner, the Hoover test and the Waddell tests may be used. Hoover test. With the patient lying supine, place the hands under the patient's heels and ask the patient to elevate one leg off the table. If the patient is really trying, there will be downward pressure on the opposite heel, which can be detected by the examiner. Lack of any downward pressure suggests that the patient is not trying to cooperate fully with the examiner. Waddell tests. Tenderness. Superficial, non-anatomic. Superficial tenderness to light pinch overlying the distribution of the primary posterior ramus of an involved nerve root is not uncommon, but superficial tenderness over a wide distribution of the low back region is unlikely to be due to an organic lesion. Likewise, tenderness to deep palpation, often extending to the thoracic spine, sacrum, and pelvis, cannot be accounted for by an organic lesion of the lumbar spine. Simulation tests. Axial loading, false rotation. The patient perceives that the lumbar spine is being stressed when in fact it is not, and therefore reports of increased low back pain suggest a non-organic influence. Vertical loading by compressing the occiput is unlikely to aggravate lumbar pain from an organic lesion. Neck pain, however, from occipital loading suggests organic cervical pathology. Rotational movements of the lumbar spine may cause increased low back pain, but when the pelvis and shoulders are passively rotated by the examiner, Reports of increased low back pain suggest a non-organic component. The production of leg pain, however, during this examination may occur with nerve root irritation and should not be discounted. Distraction tests. A positive physical finding elicited during the examination is checked when the patient's attention is distracted. If the patient had limited straight leg raising in the sitting position, the MES test is repeated while the examiner distracts the patient's attention by performing the plantar reflex and also assessing the extent of straight leg raising. Significant improvement of straight leg raising with distraction suggests a functional component. Regional disturbances. Sensory weakness. The finding of sensory disturbances over a stocking distribution rather than a recognized dermatomal pattern or a diffuse motor weakness of the cogwheel nature or partial giving way, which cannot be explained on a neuroanatomical basis, suggests functional overlay. However, patients with multiple root involvement, as in spinal stenosis or cauda equina lesions, may exhibit these regional disturbances which have an organic basis. Overreaction. Excessive verbalization or exaggerated facial expressions, muscle tension, tremor, posturing, or collapsing may also suggest a functional component to the patient's complaints. All of these tests to assess patient cooperation should be assessed during the examination of the lumbar spine and neurological examination of the lower extremities, and if non-organic signs are found, a detailed psychosocial assessment is indicated. This concludes the detailed examination of the lumbar spine and neurological examination of the lower extremities.